Hello, everyone. Welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran. I'm so happy to be with you all again from this educational platform. And first and foremost, I would like to thank all the speakers, which I'm so proud to call them my friends, who accepted the invitation and join me every Friday to be with you all and try to increase the level of knowledge and practice performance for all of us as dentists around the world, especially during the year of 2020, because of the pandemic situation and some limitations that usually we have to travel, to attend the congresses. So this is a good opportunity for all of us for increasing our knowledge and obtaining better understanding in the field that we are practicing by joining the best experts from around the world. And a very dear friend, a master clinician, Jose Mompell, is joining me, my dear friend from Spain, Madrid. Hello, Jose, and welcome to Hot Seat. I'm first
Hamid, how you doing? Hi, everybody.
very thankful that you accepted the invitation, my friend.
Thank you for inviting me. It's a great pleasure to be here with you all for taking this, trying to get closer to everyone. We'll take advantage of every single one. Enjoy this talk and this presentation I prepare for you.
Thank you so much, my friend. We are very happy and thrilled to have you. And the topic that Jose is going to talk about for us today is actually one of the very interesting topics that I'm pretty sure so many of us are excited. And me personally, whenever I listen to such topics, even if I do some of them in my practice, I'm always excited as my first time watching these kind of webinars and seminars and listening to them. And that's augmentation procedure in the posterior mandible, which I believe is one of the most challenging areas, not only from the access point, but also from the limitations that we have and the considerations that we need to think about them during the procedure. And the technique that specifically we're going to talk about today is the split bone block technique. And who can be better than Jose Mompell to present it for us, because he's one of the experts in this area. I'm pretty sure so many of us are familiar with his technique. So today we have a chance to go in depth, and we're going to have a beautiful discussion at the end of the hot seat to open up some questions about the technique and get better understanding of it. So Jose, before we start, as a tradition always, I would like to have your CV for all of our audience, and then we straightly go to the presentation and we will have a discussion at the end. Dr. Jose Mompell is a clinical professor in oral surgery and implantology, URJC master, clinical professor in periodontics, implantology, and prosthodontics at Alfonso X University master, clinical professor in oral surgery and implantology at Alcala University, and also master's degree in oral implantology at Alcala University. He received a doctorate in DDS beforehand, and he's a national, international speaker in oral implantology and bone grafting, and with dedication to implantology and bone reconstruction in his practice. Once again, so happy to have you with us, my friend, and the platform is all yours. You can start sharing, and we enjoy your presentation.
Thank you very much, my friend. Let's go for it. I hope you enjoy this presentation, okay? Let me share my screen with you all. Here we go. Can you see the screen?
Perfect.
Okay, let's go for it. We're going to be discussing for the next 30 minutes about bone augmentation in the mandible using the split bone block technique. All pictures, the whole work you're going to be, I'm going to be sharing with you today is my work and my partner in crime, Dr. Juan Lara, with one I share my practice here in Madrid. And of course, this is my beautiful city. I'm sure, I mean, knows he's already been here in Madrid, but we would like to invite you to come here. This is how it's like pre-COVID-19 and how we would like to see this city as soon as possible, full of life, full of people, okay? As Omid already introduced, this is a quick presentation about my CV and my colleague, my partner in crime, Juan's CV. And we're going to go straight to the point. We're not going to lose time about talking about me or my degrees and so on. We're going to go through the split bone block technique, split bone graft. I'm pretty sure you all know this technique. There are plenty of great clinicians, that's Howie Glugman, Maurice Lama, Frank Sastro, a lot of them who has already been here with you, me, that know the technique and have excellent cases about it, okay? But I would like to talk a little bit deep about this technique, first described by Professor Kuri, okay? It's also the split bone block technique is the so-called Kuri technique, okay? First of all, when we face a case like this, first thing we think when we face a case like this, is it an horizontal or vertical augmentation? Looking at these images, many of you would say is a vertical augmentation, but we have to keep in mind that going vertical is much more difficult than horizontal. So cases like this one in the anterior mandible, we're going to do the split bone block technique. The split bone block technique uses bone block, very thin bone blocks, like bone blades as autogenous revascularizable membranes. That's the first thing you have to keep in mind. We do not use we use autogenous bone blocks, very thin bone blades as membranes, autogenous membranes. You can see here the huge horizontal defect, horizontal atrophy we have, and we have no more than 1 millimeter, as you can see here. So now I'm going to reconstruct this anterior mandible. I know the topic is posterior mandible, but you will know, or you will see why I'm presenting you this case. So we harvest the bone block from the retromolar area. I know that many of you say this has a really high rate of mobility. And at this very moment, I would ask you one thing. Do you do wisdom teeth extraction? I'm sure most of you do. This bone block harvest has the same mobility as wisdom tooth removal. So you know how to handle wisdom tooth post-ops. You non-steroids, anti-inflammatories, maybe some antibiotics, maybe corticosteroids. So it's not a big deal. So do not be afraid about bone harvesting. You have to follow some protocols, but it's safe and predictable. The external oblique line is a safe place to harvest a bone block. And keep in mind that we are not harvesting a corticocancellous bone block. We are just harvesting the cortical part. Why? Because we want to reconstruct the anatomy. And how is bone? Doesn't matter if it's maxilla or mandible. We have an external cortical and then a spongeous bone inside. That's what we're going to do. We're going to split that cortical bone, those 4 millimeters of bone block, in 1.5 millimeter very thin bone blade. And now we are going to reassemble, we're going to reconstruct the cortical part, the missing cortical wall, okay? And this very moment you may say, hey, Jose, but you've placed implants. Yes. Why? We can place implants when doing a reconstruction, an horizontal reconstruction, when they're being placed in a three-dimensional position, optimal position from a prosthetic point of view. We need to achieve primary stability, but thinking about prosto, okay? We cannot place implants and say, okay, our prosto guy will handle and will do it. No, we need to place implants thinking about the prosthodontic work. We had a great surgeon here in Spain some 70 years ago that said, blade in the hand, the prosthodontic work in the head, okay? Our patients do not want implants, they want teeth, okay? And the static long-term prognosis. So do not place an implant. Doesn't matter if you're doing a bone augmentation procedure or not. It's not going to be placed in an optimal three-dimensional place, okay? We place it. And now, because it could be placed in a good position, we place those blades. But look here, we are leaving a space between our implant, our fixation, and the cortical blade. Keep in mind, those bone blades, those very thin bone blocks are being used as autogenous revascularizable membranes. We are placing membranes over the graft, but we need to leave a space between our so-called membrane and our implants. You would never place your implant and then a collagen membrane on top of it. You would place some kind of biomaterial. In this case, my biomaterial is going to be autogenous. Why? Because it's the one that has the three outstanding properties: osteogenesis, osteoconduction, osteoinduction, with no antigenicity. Okay, I know allografts are very safe, but here in Spain they're being now they're allowed, but some years ago they were not allowed because they were like in quarantine due to the mad cows and all of many diseases as AIDS or I strongly believe they're safe. I use them, but every single time I can use autogenous bone, I use it rather than any kind of biomaterial. Look, we reconstruct with smooth edges, no sharp edges, no corners, and we leave a space between our implant and cortical blade. With suture, no tension sutures. We always try to use at least 5 or 6 serious non-resolvable sutures. And look how it looks like only 4 months later. We are waiting 16 weeks. We do not need to wait 9 months or 12 as when using 50-50 or PTFE membrane, just 16 weeks, 4 months. This present, I don't want it to be a presentation to compare and contrast advantages and disadvantages of many different techniques. I just want you to, I just want to present you the technique and the results we are obtaining when doing this. Look, 16 weeks later, this is how it looks like. Just 4 months later. Look at the implant. It's being covered by bone. If it's covered by bone, it must be vital bone. Where is the bone blade? Excuse me. Where is the thin bone blade we place on the buccal? We can hardly see the difference between the bone blade and split bone and the recipient side. Okay, now we remove those osteosynthesis screws. This is the buccal view, and maybe I can tell you that around 85–90% of our cases, what do? We get a trephine burn and we take a bone core biopsy. Why? In order to see how much vital bone we're having, because this, yes, it looks like bone, but we need to have a proof. That proof comes here, where you can see the lacunae with this pigmented nuclei inside. That means it's a vital osteocyte, okay? Sometimes you can see on the outer part, the nuclei not being involved. So that's the osteoblastic line. That means that it's vital bone, immature bone. Keep in mind, it's only 4 months old bone. So it's a vital bone, immature bone, but absolutely able to integrate implants. Look how it bleeds. Here on the left side of your screen, you can see the blade. You can see our autogenous revascularizable membrane that it will remodel within a little bit more time. But look, blood is coming out our implant preparation. It's not contamination blood from the outside. You can see how it comes from the inside. We place our implants, and now, as long as we place those implants when doing augmentation, we can start working on our provisional bridge from K9 to K9. This is how it looks when we re-enter to do the second stage surgery. 10 to 12 weeks later, we're waiting same time as you will wait for a normal implant. This is how it looks like in 2000 2015, and this is how it looks like 4 years later. So the artiform shape of this anterior mandible is maintained. But to this point, I'm sure that many of our colleagues that are watching us, I mean, we say, hey, I would never harvest the bone block for that. It's too risky. I want to have it under sedation, although most of our cases, we do it just under local anesthesia, but I don't want to harvest the bone block. I would do it just with my collagen membrane, maybe PTFE, even a titanium mesh. Yes, and I agree. It's an option. You can perfectly do it. But we're going to go through a posterior mandible. We cannot even insert short implants. So what then? We need to go vertical or go home. You cannot, you have like 4 millimeters over the alveolar nerve. So what do? Either you strike the whole teeth, the whole rest of the teeth, and place a hybrid prosthesis, or you need to go vertical. And what's the biggest issue about going vertical in the posterior mandible? I'm sure that if you do bone augmentation procedure, the biggest problem is bone exposure. One is bone exposure, one is bone resorption. Bone resorption, when doing this Kuri technique, we can reduce almost to 10% after the first year. You will see in the bone resorption and bone exposure. How can we reduce that bone exposure? Through a tunnel approach. Tunnel approach is not new. It was developed by Kent in 1983. And then many authors have used this approach to do different techniques like PTFE membranes, allogenic bone grafts. Ponzi used it for the Kuri technique. And Lucas Tabola first published in 2013 10 cases, maxillomandibular cases, using this approach for with a 1-year follow-up. In 2015, our team, commanded by Dr. Ristoy, the hospital in Madrid, we published 50 cases, mandibular augmentation, posterior mandibular augmentation, vertical augmentations using this tunnel approach. Let's see a couple of cases for you to understand, really understand this thing. If you see this lady in her 50s, first of all, we think about short implants. Come on, display like 6-7 millimeter implants. We split the implants, and that's gonna go perfectly well. That's gonna work. We know short implants work, but when we go to the CVCT, we can see that to place the implant in a proper position from a prosthetic point of view, we should have tilted a lot. It will 1.5, 2 millimeters over the nerve, and we place a 7.5 millimeter implants, we could do just an horizontal augmentation. If we want to place and stand around 10 millimeters, we need to go vertical. In these cases, we never consider doing a split technique, the split crest technique, because first thing, in our opinion, to do a split crest is that the lingual cortical must be stronger than the buccal. Otherwise, when doing the split, you may have a bad split on the lingual side, which can be a nightmare. So let's continue with this. We're gonna do our tunnel approach. Tunnel has two big advantages. First of all, no incisions over the crest, no incisions over the area that is being reconstructed. So if there is no incisions, we cannot have a wound dehiscence. To have a dehiscence, we need to have an incision. So there is no incision, no wound dehiscence. We're reducing almost to zero the exposure. And the second big advantage is that the periosteum that is going to cover our graft is intact. It needs no repair. So its osteogenic capacity is going to be also intact. So first of all, we do two vertical incisions. We connect them through a subperiosteal tunnel approach, and we locate mental nerve, as you're seeing in this image. As long as you locate it, you will not damage it. At the end of surgery, you will see it's in its place, and maybe your patient may have some paresthesia, but it is absolutely temporal. Okay, it's absolutely temporal. And for those who are concerned about bone grafting because of the paresthesia, I can tell you that paresthesia are related to this approach because you are reconstructing the area where the mentalis nerve is located, not with bone harvesting. And how do I know this? Because when we harvest a bone block to reconstruct the upper jaw, the maxilla, we never have paresthesias. So that's why we know that it's more related to the manipulation of the mental nerve rather than the bone harvesting. Okay, we do our tunnel approach, we locate our mental nerve, and now we are going to reconstruct the area. How? With this split bone block technique, a very thin bone blade on the outside, and then particulate bone in the inside. Okay, that cortical bone is going to prevent from resorption, it's going to prevent from chewing forces and so on from bone resorption. And on the other hand, the particulate is going to revascularize very, very fast. And thus, we are merging the characteristics of both, because I'm pretty sure that some of you will say, I only use bone blocks, pure bone blocks, or from the mandible, which they have no resorption in the short time. On the long time, they have resorption. I use iliac crest grafts. Iliac crest grafts, they revascularize quite fast, but they resorb on the short time. With this technique, we are characteristic of both cortical bone and spongious bone. Okay, we are protecting the particulate bone in the inside with our cortical blade, with our autogenous revascularizable membrane. And now what? We finish our buccal reconstruction with the buccal plate. Keep this image in mind: crestal blade, buccal blade, and particulate bone inside. We suture, okay, and 16 weeks later, this is how bone looks like. You can see the little holes from the screws. You can see a little difference between the crestal part and the part, but it's not, I mean, it seems like bone. It is bone, and we're gonna place our implants, and also what is our bone core in order to see if it's vital bone or not. Normally, when we take this bone course, we try to have the 1 millimeter cortical blade, the 4 or 5 millimeter particulate bone, and 2 or 3 millimeters of the recipient side. That way we can compare and contrast the quantity and quality of the bone that we are going to insert our implants. We insert our implants, and always we try to place it a little bit, as long as we are using, like this case is side implants, a little bit. Why? We are using these membranes, these bone blades as autogenous vascularizable membranes. You would never place your implant touching your membrane. So I go a little bit deep, 0.5, just in case bone remodels. Keep in mind that it was immature bone. Within first year can remodel a little bit. I don't want to lose 0.5. So I go a little bit deep. Or you use implants with polished neck, okay? What here? It could take a long time, but this is a Cathangian approach, okay? We have to know that with Cathangian vestibular the approach, we are going to have attached tissue around our implants, not keratinized, but attached. So if we have 3, 4, 5 millimeters of attached gingiva that will be surrounding our implants, we will do a Cathangian vestibuloplasty in order to have a deeper font of vestibule. We always finish our implants with keratinized tissue, okay? As I've heard a lot of times said, tissue is the issue, okay? We want tissue around our implants. Keratinized tissue is our seatbelt, okay? It is mandatory to have keratinized tissue around our implants for long-term prognosis. This is how it looks like 10 to 12 weeks later. So now we are healing gaps, and that is how the x-ray looks like. This is the post-op x-ray. Do you remember on that posterior mandible we had that arthiform defect? Now we have to talk to our patients to do the left side. So let's move on. Another case. Okay, we have this lady. Nowadays, I don't know, in your practice, I'm sure that it happens all around the world. We are facing more and more patients that are losing implants. Okay, standard implants or short implants, and they go to your office, a 45-year-old male or female saying, okay, I lost my implants, they were placed 10, 12 years ago, and I do not believe that in the 21st century, I have to remove my whole denture to have a fixed prosthesis. I've gone through augmentation procedures, I've gone through short implants, and now what? I want to have my fixed teeth. This is the case. Okay, let's go to the CBCT around slice 77, and this is how it looks like. That's the alveolar nerve. We're gonna leave like 1.5 meters. We have 3-4 millimeters above the nerve. We cannot place a short implant here, so we need to go vertical. And we're gonna do the same technique, okay? Vertical incision, remember, 2 advantages of the tunnel, no incisions over the crest, integrity of the periosteum, and now we reconstruct the area. Our cord blade on the upper part, particularly bone inside, well packed, and the buccal wall, as you can see here. And look at the X-ray. This is the fused X-ray, and this is the post-op X-ray. In looking at this X-ray, I will give you another tip. It's absolutely mandatory to do a predictable reconstruction to have a bone peak distal to the last tooth on the arch, okay? We cannot grow bone over exposed roots. That's not predictable. You can't try to do it. You can use Endogain, you can use PMPs, you can use wherever you want, but it's not predictable, okay? Science is that same protocol with same materials in more or less same trained hands obtain same results. So to have predictable results, you need healthy bone on the sides of your reconstruction. What if I have exposed root of that second bicuspid? Either you do nothing, either you take the risk, but knowing that it's not 100% predictable, or you can extract that tooth and obtain a healthy bone peak on the mesial part in order to have your reconstruction, okay? This is how it looks like, the reconstruction. You can see the cortical, the crestal cortical, the particulate bone inside. You cannot see the buccal because it's a panoramic X-ray. This is how it looks like 16 weeks later, 4 months later. We place our implants, and look, this is prior to the augmentation procedure. This is later. Look what happened. We had, before the augmentation, we had a corticalization of the crestal part. And when we did the augmentation, what happened? It remodeled in order to be as a normal bone, okay? This is how it looks like, okay? We augmented, we had this 3-4 millimeters, and we augmented those 9 millimeters. So many times, if we do not have keratinized tissue, we do free gingival graft. Maybe before the placing the healing caps, maybe at the time of healing caps, okay? This is 2013, and this is how it looks like 4 years later, okay? This is a case we didn't do at our office, we did it in somebody's clinic, and this is how it looks like 4 years later, okay? So this last case is a very interesting case, and we want to share it with you because it's a 32-year-old female that comes to our office asking about implants in that posterior area. She has already lost 2 implants, and in many places, many doctors have proposed her to remove from first bicuspid to the other bicuspid in order to place 5 implants and hybrid prosthesis. She doesn't want to lose all her teeth with 32. So look, you see here all the scar tissue, and let's go for it. Look, the CBCT. This is the day we did the surgery, January 23rd, 2012. And look, we have bone peaks, healthy bone peaks adjacent to the defect, and we cannot place even short implants. Why? Because we have 0.3 centimeters, we have 3 millimeters above the nerve. We could do a lateralization, but we will place our implants very, very deep. Soft tissue would not be good. and you cannot do inlays here because you need to have to go up. You cannot do distraction. Here you need to do on-line techniques, either Kuri technique, split bone block technique, or go vertical with PTFEs, okay? This is an augmentation of the area, 2-3 millimeters, and we're gonna do same technique. We harvest block from the retromolar area, from the oblique line. Look, but I never said from the ramus. I always say from the retromolar area, okay, where the wisdom tooth located. The sternal line, the oblique sternal line is where we are going to harvest our bone block, okay, because it's the area where the alveolar nerve is far away from the cortical in the mandible, and we are going to split this bone block. Look, it's only cortical in 2 very thin bone blades, 1 millimeter more or less. We're going to place our bone blade on the crestal part. It's going to be touching the mesial bone peak and always distal bone peak. And many of you will say, what if there is no distal bone peak? There is always a distal bone peak. Why? Because mandible always goes up at some point. You may need a bigger bone block, but you always have a distal bone peak, okay? We place our thin bone blade, and we finish the record as we've been seeing through the whole presentation. We suture, and we normally wait 14 weeks. We see the patient in our office, and we talk about the date for placing our implants. When she came to our office, said, no, guys, you're not going to be able to place my implants. We said, why? Because why? She had, it's a financial issue or what? I said, no, there's no financial issue. I'm pregnant. My doctor said, no surgery for me. It's a risk pregnancy. No surgeries for me till I deliver my baby. So we need to wait a whole year. What is going to happen? That's what I said. It was an interesting case. It's going to happen with this autogenous bone after a year, because many colleagues say autogenous bone, it resorbs. That's a dogma that I'm pretty sure many of you have heard. And it's true. Autogenous bone may resorb if not used in a proper way. So let's see what happens 13 months later. You can see the date here, February 2013. This is how it looks like. Everything that was contained in the bone frame stays stable, as you can see here. Now what? Now this is how it looks like 13 months earlier, and this is 13 months later, 1 year and 1 month after the augmentation. We can hardly see the difference between the recipient side and the augmented bone, and we cannot see where bone was harvested from. Cathangent approach to place our implants, and look at this image. We can see even this buccal mesial screw being covered by bone. That means it's vital bone. Now what? Bone core to see what happened with that bone after 1 year, and we place our implants. Okay, as you can see here, normally in a free end, we try to place 2 implants. We try to split both implants in order to protect one each other, have less loosening screws, less fracture of the prosthodontic work. We can't talk about this a long time, but we like to place 2 implants in free ends. This is how it looks like. Our implants in place, suture of the cathangent vestibuloplasty, and let's take a look to the X-ray control, because this is really interesting. This is prior surgery, 13 months later, and at implant placement. And what do you see here? Because I'm sure that some of our colleagues, are thinking about, okay, guys, you place a crestal bone blade, buccal bone blade, but what's going on the lingual? You did not place a lingual blade. What happened to the lingual when using this tunnel approach? Look what happened. We have even a more dense, more powerful cortical blade, cortical wall on the lingual side than the buccal. And that's because we did not raise a flap. We did our tunnel, and the lingual periosteum stays in place, and we pack particular bone against that lingual periosteum that has osteogenic capacity intact. As you can see in those images on the right side of your screen, we cannot see I'm pretty sure that many of you could say that was a harvest bone. That was an augmentation, an augmented bone. Some at this time 10 months later, because it was before second stage surgery. As a finishing this case, prior, after the augmentation, and this is the 2 implants in place. And second stage surgery, it took a little bit more, 5 months. Why? Because this young lady, mother of 3, like ballet, football, soccer, and wherever, it took 5 months to come to our office to do the second stage surgery. How it looks like the day we did second stage surgery. If I show you this periapical x-ray at the very beginning, I'm pretty sure that not many of you could say that is an augmented bone. Okay, this is how it looks like. We split the keratinized tissue we have and place our healing caps. Okay, we want at least 2-3 millimeters of keratinized tissue surrounding our implants. This is 2013, and this is 2019. Distal implant is suffering a little bit. Hygienic is not the best. We need to remove these crowns and clean everything a little bit more. All these cases, I mean, it's just 3 cases, 4 cases I share with you today. We presented to the scientific community in 2015 the reconstruction of these posterior mandibles, 50 cases in this technique through a tunnel approach with a follow-up up to 5 years. Okay, so if any of you are interested, feel free to contact me, and we will send you the paper. And you can also go to our website to see many other different places, many other locations, such as this one, where we merge different techniques, split bone block technique and titanium meshes, and to achieve this kind of results. So this is our contact, our email. If any of you have any questions, feel free to email us, our website, and also our Instagram. So if any of you want to share any question, any ideas with us, please feel free. We receive and we try to answer as soon as possible. Thank you for the opportunity, Omid, and let's chat for a little bit.
Yeah, sure. Thank you, Jose. Actually, you presented in a very, very easy way. So maybe some practitioners, especially the beginners, think that it's very easy to do it with 2 screws and just a plate. But I think what we should really know that in every technique, we should know how to set the steps, and it needs the skills, and we need to have enough experience to go step by step to achieve the beautiful results presented. So actually, it's one of my interesting topics too. So I'm really excited to talk about it with you. And before I go to the hot seat discussion session, I would like to say that for all of you interested, I encourage you to follow Jose Instagram page if you want to see beautiful, beautiful cases by him. He presented the website and everything, but you can easily go to his Instagram page, join the page, and enjoy his magic with split bone block. And for all of you interested, his partner in crime, Juan Chao, gonna be my next guest on Hot Seat, so can't wait for that. So you will see both partners in crime on Hot Seat soon. So, Jose.
Yes, you will. Yes, you will.
Yeah, sure. My next question is regarding the preparation of the tunnel. First of all, should we always go with 2 incisions at the beginning and at the end, or is it possible to also go with only 1 incision in the mesial?
Okay, that's a great question. First of all, I'm taking your words. I mean, I absolutely agree with you. Okay, this is not an easy technique, not for beginners. You cannot go first day to do a tunnel and vertical augmentation. You're gonna crash. Okay, you're gonna say this doesn't work. You need to go horizontal at first. You need to go easy at first. Okay, and maybe you may think about, oh, I would do this with some biomaterial and a membrane, that's the best case to go horizontal. Why? Because if everything goes wrong, you can crush your bone block, you get some particular bone, you place also, you have 50-50, and you place your collagen membrane, and that's it, you solve the case. So you need a learning curve. But I can also tell you that we have 10 fingers. We teach this at the university. We have plenty of colleagues doing this. Okay? This is not magic, this is science. Same protocols, following same steps, with same materials, in a same way trained hands, you obtain results. So you can do it. It's just a matter of learning and practice. Stay hungry, stay foolish, stay, as Steve Jobs said, stay willing and pushing to learn. Now, answering to your question is a great question, and it's an advanced question. And I'll tell you why. Is it mandatory to do 2 incisions? No. You tunnel is only mandatory to do the first, the mesial incision. But, so people, why do 2 incisions then? Because the distal incision of the tunnel is the mesial vertical release to harvest my bone block. Okay, so just imagine that I'm harvesting the bone block from the contralateral side. So I'm reconstructing the left mandible, and then I'm going to harvest the bone block from the right mandible. At the moment, I would own 1 vertical incision from my tunnel on the left side. The less incisions we do, the better post-op, the less complications. And the 2 incisions, the reason of the 2 incisions is because of the distal one is the mesial for harvesting the bone block.
But can we say that if we put 2 incisions for the tunnel, the pressure of the soft tissue during the healing phase on our bone graft underneath will be less? Can we say?
Yes, it can be less, but it is less for sure. But you have to bear in mind that it's a balance between pressure over the graft and also blood supply that comes from the distal. You need to have those 2 things in mind, okay? And remember, when we do our tunnel, we raise a sutural approach, but we only raise buccal and crestal. We do not raise lingual periosteum. If we raise lingual periosteum, what would happen? I mean, every single particle of bone that you pack through the tunnel towards the lingual periosteum will go towards the floor of the mouth. So you cannot raise lingual periosteum, just buccal and crestal.
And Jose, there is one question that become now that if we only put 1 incision for the tunnel, then how we can fix our distal screw in the plate, because there is no access from here to go there. Maybe that's why we prefer 2 incisions or harvest on the same side.
Yeah, I mean, harvesting on the same leg is you only have 1 surgical site, okay? Your patient doesn't know if you're using this 2 centimeters or 4 centimeters left mandible. So that's why I like to harvest it from the same side, and I will leave the other side for him to be able to eat a little bit, although I recommend soft a couple of weeks. But yes, it's easier if you have a second incision to place the distal screw. But I can tell you, my colleague Juan, he uses distal incision many times to fix the distal screw. I personally only use the mesial incision. In many of my cases, what will you see? You will see a very long screw from the mesial all the way to the distal part. That's it, oblique. The first this on the mesial, and the second one will be like this. That has another good thing. As the more this parallelism that the screws have, the more fixation our graft will have. If we place our screws parallel, our bone graft may move. But if one of them is like this, it cannot move, okay? So, but you can do it. I mean, I use only the mesial, most 90 cases, I only use mesial incision. And when we go to the maxilla and we do a vertical augmentation on the posterior maxilla, see in Juan's cases, we only use one incision. It makes no sense to use the other one because you will not be able to place your screw incision. So we only use the mesial one.
That was a great point. And one of the points that I would like to know your thought on that is about the time of screwing those plates. Because in Kuri technique, some people, or a split bone block technique, some people use their like imagination that, for example, the thickness of the plate is about 1 millimeters and I want to build 3 millimeters of bone and the residual bone is about 3 millimeters. So they first put the screw like 3 millimeters in outside the mouth and then go inside the mouth and they screw it. So do you do the same thing, or you just put the plate in the area and try to screw it in the mouth? So what is your approach?
Okay, I'll tell you. You cannot you cannot drill outside the mouth and then put it in, because you will never find the hole you did in the mandible. It will go in another axe. So it's very, very difficult. What I do is I take my bone blade, 1 millimeter, I go through the tunnel, I place it on the crestal, first the crestal, and it will be supported, it will be held by the 2 bone peaks adjacent to the defect. Okay, it still there. Okay, and then I drill, and people would say, if you have 3 millimeters, I never look for the place where I have amount of bone to the nerve. I always go where I try to have the biggest amount of bone to the nerve, where I can drill safely. Okay, I never drill out the mouth. You can use, to harvest the bone block, you can either use piezo or microsaw kit. I use a lot of the microsaw, and with the microsaw they come with these little drills that is 0.6. I might do it outside the mouth in order to stabilize my bone, my drill, my screw system drill. We've designed a special system in order to have a better or a faster or better chances to fix it at the first time.
Yeah, but the point was that you said that your plate should be anchored or supported by the bony peak. So when you screw, there is no way to go down. So imagine if we wanna put the second plate in a horizontal direction. Do you do the same thing, or put the screw before and then put it in the mouth, or you screw at the same time? Because if you screw at the same time, it may...
No, I do it. No, I place the crystal, and you need to have something like a pair or skitty tweezer or whatever to hold it in place, just not to do this, because it can bend towards the buckle. And when you're placing the buckle, it's very, very, very easy. Why? Because normally your defect is artiform, is like this, but your blade is rectangular. So where will you place your screws? If the defect is like this, and my bone blade is like this, just go to the places where there is no defect. It's gonna be easier. You need short screws, 6 millimeters, 7 millimeters, 5 millimeters, no more than that.
Right.
And another thing, no more two screws for each blade. But if at any time we hesitate, it has a little mobility, we place a third screw.
Yeah, great. And regarding the vertical incisions, I noticed that your incision goes through the sulcus, right? So we go sulcular, we go to the lingual, and we come passing the mucogingival junction, right?
Yeah.
So you all...
Yeah. The thing is that you cannot respect the papilla, the distal papilla. Why? Because if the papilla is here, it's because both the papilla. Yeah. If you do your incision taking care of the papilla, where is going to be your bone block? Your incision is going to block. So tunnel makes no sense. You need to go intrasulcular and then go a little bit slightly towards the mesial part. You cannot respect the papilla. You need to place your bone blade touching that bone peak that is supporting the papilla.
That was a good point. And do you prefer to do the decortication in split bone block technique or no?
That, that's a really, I know there are a lot of colleagues that do the corticalization. They say it promotes angiogenesis. I think it's not necessary. I think it's not mandatory. But I do many times. I take my safe scraper, my bone scraper. I have my tunnel, and then I scrape a little bit the area that has two advanced of all. I'm recollecting bone, cortical bone, which is being proved to have the most quantity of BMP2. Okay, cortical bone has the most quantity. I'm recollecting bone, and at the same time, I don't know if it works or not, but I have a bleeding surface.
Yeah.
I'm not doing it because I think it's mandatory to promote bleeding of the cortical, but as long as I'm recollecting bone and it's bleeding, I think it's not going to do any damage. If
And
you don't know want to do it, don't. It's going to work perfectly well.
yeah, so you prefer to go, yeah, actually it seems logical because at the same time, not only you collect the cortical bone and you have more bone, but also at the same time you're exposing the trabecular bone underneath, and so you have more availability of the vascular supply to your bone graft. So regarding the management after your split bone block technique with the tunnel approach, you presented free gingival graft, also the Kazanjan technique. Which one do you prefer? Is there any preference regarding these two, or it's just a surgeon's preference, or do you find any superiority of one comparing to the other?
Okay, that's a really good question, and it's also an advanced question. Everything is based on diagnosis. I look at my patient and I see if I have my seat belt. What was my seat belt? Keratinized tissue.
Mhm.
If I have tissue, I tangent. At the same time, I place my implants. So just one surgery. Because with pre-gingival growth, you obtain keratinized tissue. With Cathangian vestibuloplasty, you do not obtain keratinized tissue, but attach mucosa.
Mhm.
So if I look at my patient, I have keratinized tissue, I have my seatbelt, I go Cathangian at the same time. If I look at my patient, I have no keratinized tissue or very little, I place my implants crestally, little incision, and then I go free gingival graft. Okay. The main issue is to see if we have our seatbelt in place. If we have a seatbelt, if we have keratinized tissue, I can go Cathangian in order to make our fauna vestibule deeper. If not, I go free gingival graft, obtaining better keratinized tissue. Free gingival graft has more superiority in order it gives better quality soft tissue around our implants. But on the other hand, it has an issue that is you need a second surgical site, which is the palate, and some patients would be reluctant to go for it. You may have some complications, bleeding, blah, blah, but sometimes it's mandatory to do it.
And Jose, do you find any number or critical number for the keratinized tissue that you're mentioning? For example, if I have only 1 millimeter keratinized tissue, I say that it's good, or do you have or define limits for that?
Okay, I'll tell you a number because I want you to have the number we normally use, but let me answer with another question. I study at the Complutense in Madrid with Dr. Mariano Sanz. I'm pretty sure you know him, and many colleagues. It's one of the most prolific groups of investigation. And I can ask you how many or what's the number of millimeters you need to have health around tooth? How many millimeters are mandatory to have of keratinized tissue around a tooth? And they will say there is no number. The number is the amount of millimeters that our patient is able to have good hygiene, not plaque, no tartarus, and so on. So in implants, it's more or less the same, but with another thing. we have to keep in mind that our patient has lost the tooth, okay? So most of the time are not the cleanest patient, their hygiene is not the best. So it's even more important to me to have at least 2-3 millimeters keratinized tissue 360 around our implant, okay? We cannot forget about the lingual side, okay? Buccal pictures are nice, but we need to see the lingual side. Those patients come into our office saying, doctor, my implant hurts. Implants cannot hurt, okay? Unless they are moving. It's the gingiva. And many times it's because we have no keratinized tissue on the lingual. How do we solve that? You can do a lingual gingival graft, which is kind of difficult. What do? We remove our crowns, place cover screws, let it heal. If it doesn't completely heal, it's okay. We do a free gingival on the buccal, 6, 7, 8 millimeters. And at the heels, we split it and do a lingual repositioned flap. In order, we have 4 millimeters in the lingual, 4 millimeters in the buccal, okay? But minimum is 2.5, 2.5 to us. If less, we do free gingival.
That was a good. And Jose, you talked about utilizing allografts. I believe that in many countries, people tend to use particulate grafts, substitutes. And as far as I know, and also you mentioned, the gold standard in Kuri technique or split bone block technique is autogenous bone. And all the people, experts in this field like you, they prefer to feel the area between the bony housing and the bony plate or bone blade with the autogenous particulate bone. But you also mentioned that it's possible to use allograft in this bone split bone block technique. So do you find any difference if we harvest a bone plate for split bone block and harvest between autogenous particulate bone or the allograft one?
Okay, first of all, I have to tell you that I have no experience with allograft bone blocks. Okay, I allograft bone blocks. I know of my patients. I know that some of you say that's not true. None of my patients says no to bone harvesting. It's just a matter how you, allow me the expression, sell the story to them. Okay, if you tell them this is traumatic, I'm going to take a piece of bone from here, they will say, whoa, do not do that to me. But if you go and say, okay, I'm going to take a little piece of here, it's just a wisdom tooth removal, you do not have wisdom tooth, it's the same, a little pus-up, and you talk to them, they will say, they won't say no. That's why we always use autogenous bone. Okay, the gap, I will always fill it with autogenous particulate. Why? Because it's the bone that is going to integrate my implant. Okay, if at any time I lose 1 millimeter, 1.5 millimeters, and you get material, perimplantitis is gonna go as fast as a lightning. Okay, the biomaterials, bios, I know it's not an allograft, but bios or any other substitute, they are great as osteoconductor, as an scaffold, because they are porous and the bone cells can invaginate and can create or make bone and facilitate bone fusion. But as long as they're porous, they're also a great environment for bacteria when they reach that biomaterials. The perimplantitis goes faster in bios, although it's perfectly integrated in my implant, than in particulate bone. But if you tell me about the very thin bone blade of allograft for the crestal and the buccal, I have no experience. You can use it. I recommend you to place your implants a little bit deeper, just in case you have any kind of issue with that cortical blade. Your implant will be integrated in your autogenous bone. Okay. And another thing, I do not use allografts, and I know that many people say allografts are osteoconductive and osteoinductive. As I'm pretty sure you've heard that. I mean, I do not like to say or use them. I do not like to say they're osteoinductive. Why? Because being osteoinductive, the osteoinduction is promoted, is based on the BMPs. That's right. Osteoinduction is based on the BMPs. So if we say we have an allograft that is osteoinductive, means that has BMPs from a donor, which means that we cannot say 100% that is it has no antigenicity 100%. They're safe for sure. Can we say 100% they have no antigenicity? If you say they have osteoinduction, you cannot say that. That's why I like to say they are osteoconduction, very good osteoconduction, but no osteoinduction.
I totally agree with you. I personally don't believe that allografts have osteoinductivity, the dimineral, because even if you're counting on the amount of BMP, that amount is very little that I believe that they cannot do anything. So osteoinductive. So with that said, Jose, I think your topic, as I said at the beginning, is very, very interesting. And first of all, I want to for going in depth of the technique and for your patience to answering all these questions. And I believe that one of the techniques as an implant surgeon, everyone should become expert in it because it's like a gold standard. And if we compare split bone block technique to other techniques, especially in the field of vertical ridge augmentation, I think we can call it a gold standard because I like these two words I always hear from Howie Glockman, that he always says that I need a technique to be predictable and reproducible. So this is one of the techniques that we can say if we do them right, they're predictable and most importantly, reproducible. That's, I think, the key for choosing a technique, especially in the compromised situation like Mandible. So my friend, first of all, thank you so much for your time, for joining. I'm really looking forward to see you very soon everywhere in the world, and especially in Madrid, in beautiful Spain, which is one of my favorite countries in the world. And I hope you stay safe, and hats off, my friend, for your beautiful job.
Thank you, Omid, for giving me this opportunity and following your words. I absolutely agree with Howie, and I will add that Howie is absolutely a master in this technique. But I can tell you that with training, Howie does a lot of training. We do, and you can reach this. Every single person that is listening to us with some training, following a protocol, will be predictable and reproducible. Man, I mean, they will be able to do it at their offices, okay? Because this technique works. Thank you very much, Omid. Thank you all for being here with us today. I hope you enjoyed. If there is any question, please do not hesitate to email us or contact us through the Instagram. Even if you have some cases and you've done some augmentations and you want some little tips, I tried to give you, I didn't explain the technique because it could take for hours to explain biology, why it's really interesting why this technique works better than some others. But please do not feel ashamed of asking. We've placed a lot of questions to our mentors. I played a lot of questions to people as well, Maurice, Howie, the Dr. Khan, a lot of them, and they will all answer. And if I can help you just a little, please do not hesitate. Thank you, Omid, once again. I hope you enjoy. Thank you for this great platform.
Thank you, Mike. Stay safe. Take care.
Take care.